Let's talk about the sepsis in the ICU. And so, what is the earliest bedside signal that makes you suspect sepsis in the ICU? Often, more before the scores and the investigation confirms it, and it's more of the clinical gestalt versus scoring tools.
Yeah. Yeah, that's a very good question, and of course a big challenge. And I think the problem is that we often think that there is just one typical way in which sepsis presents in to us. It of course depends on the setting where you are. I think if you're in the ER, for instance, that well, signs may be more obvious in some patients. Some patients come with overt clinical signs and symptoms, typically respiratory infections, abdominal infections, urinary tract infections. They come with a clinical a type of clinical presentation that is, I'm not saying hard to miss, but offers typically a lot of clues if you properly, investigate your patient. If you do like clinical investigation, something that a lot of people forgot about. But diagnosing pneumonia, intra-abdominal infection, and urinary tract infection with patients who have the typical signs and symptoms, I think is pretty straightforward. Albeit, of course, that not in every patient this is the case, especially patients, at the extremes of ages, patients who may have neurological or other disorders. It may be very difficult to tease that out and, being put in the right in the right direction. In the ICU, of course, it's different, and it depends on the way the patient's been behaving. In some patients, of course, you always need to think what I call contextually. This means that in a patient who has been admitted 4 days after abdominal surgery that was difficult, in a patient with a lot of comorbidities and now presenting with abdominal pain, well, I can tell you that this patient will unlikely have a catheter-related infection or a meningitis, but it's very likely that this patient will have like an abdominal infection, and this should be your primary target. And where maybe you may think, well, maybe this patient has also urinary catheter, could be a urinary catheter-associated infection. Well, it could be, but it's still more likely to be a abdominal infection, giving the abdominal signs and symptoms. If that same patient presents with respiratory symptoms, a lot of sputa, have had difficulties breathing when you ask the patient or when you ask the family, then pneumonia is like a logical alternative diagnosis. So again, I think we need to understand the clinical signs and symptoms, and in that way, the earliest signs of sepsis is really dependent on the type of patient. The biggest challenge, if you ask me, is the patient who's been on a ventilator in an ICU for some other, with maybe traumatic brain injury, that had a little bit of aspiration, and then 3-4 days down the road, you see the FiO2 going up. You see maybe some other clinical signs and symptoms of infection. You have some sputa, you have maybe some elevated biomarkers, and that's the patient that is more challenging, I think, where you need more information prior to initiating antimicrobial therapy, provided, of course, you are there early. If a patient is presenting with septic shock, then antibiotics need to be administered swiftly. If you're really not sure, and again, I'm sure that anybody who works with patients sees that clinical scenario, then I think more investigations, also involving microbiological sampling, etc., is required to make the correct diagnosis.
So once we suspect sepsis and I know this patient is in shock, we talk of the golden hour, and there are too many things to be done in that golden hour. We have to give antibiotics, we have to give fluids, we have to also speak about the vasopressors. So how do we
Mhm.
prioritize antibiotics, fluids, and vasopressors? So what truly saves time and lives?
Yeah. Well, I think it's not just one. I think you need to do multiple things at the same time. And luckily, our brain is, constructed in such a way that we can do multitasking, right? I think at the same time, you can think of, well, or you can diagnose a patient and see this is an infection. This patient has severe hypoperfusion. And this is where, of course, your actions are aimed at improving that perfusion. So administering fluids as a first strategy does make sense. You will immediately have a blood pressure. If the blood pressure is really low, you may even early on already administer vasopressors. And at the same time, of course, you do understand that you're treating a patient with an infection. And there's only two things you can do to treat the infection that leads to sepsis or septic shock. The one is antibiotics. The second one is controlling the source of the infection. So this patient needs antibiotics, fluids, maybe vasopressors. and also source control or consideration of source control all in parallel. This is not like prioritizing one over the other. I think this is, you know, often you get the question, should I start first with fluids or should I start with antibiotics? I mean, you give both of them at the same moment. Why is there a choice to be made? It's not necessary from a practical point of view. Okay, maybe there can be like 1 or 2 minutes in between either intervention, but I don't see why you are not using both strategies. And this consideration for source control, I do want to emphasize this because if you want to consider source control and the need for source control, it is imperative that you have a diagnosis, not a diagnosis of sepsis, but a diagnosis of infection. Where is the infection? Sepsis is all about quantifying the host response to sepsis and quantifying organ dysfunction that is, reflecting this host response. But diagnosing infection is different. You need a focus. You need to identify a focus, and for that you need your eyes, you need your hands, you need your brain to kind of prioritize. If a patient is admitted, for instance, from the neurosurgery department, who's had an extraventricular drain for 2 weeks, and now is coming with like undetermined fever, no typical respiratory issues, but high fever and in shock. Well, that patient is more likely than anybody else to have like a ventriculitis, nosocomial ventriculitis. And you may still be worried about pneumonia, and you may still be worried about urinary tract infection. But in terms of probabilities, I mean, this patient should be treated first for that cause, or you should aim all your investigations toward confirming or refuting the diagnosis.
So, very rightly said. So, when we talk of whether the fluids or the antibiotic or the vasopressors, as you said, all can be given at the same time, it will hardly will be a difference of a minute or two. So now, when I decide to give a fluid, and we have discussed about the liberal versus restrictive strategy, we talk of 10 mils per kilogram, maybe it's too high. So, how do we determine the optimal fluid strategy, especially in a mechanically
Mm.
ventilated patients, and
Yeah.
how do I start with it?
As for so many intervention, of course, it is a bit naive to think that it's choosing between A and B for your patient that is the best solution. I think conceptually the best solution is individualized treatment, but that is easier said than done. So I truly understand that, but that should be the basic strategy. We do know that massive fluid overload is not a good thing. We've learned this. And a lot of studies have shown that when we over-resuscitate patients, that's not a good idea. But this is, applicable to so many other things. I know very few things where you overdo them, it brings benefits. But we need to understand, we need to use this in clinical practice. Now, at the same time, I do think there is also still a risk of under-resuscitating a patient. And now I see more frequently patients who are under-resuscitated with also significant outcomes. So this is really this U-shaped curve where you give too much, it's not good. Where you give too little, it's also not good for your patients. I think we do not have to be too afraid to load the patient with fluids initially. I think we've become much more conservative. And what contributed in the past, I think, to this fluid overload is not the fluids that were administered in, say, the first 6 hours, because this is not where you give 10 liters of fluids in 6 hours. It what happens over the first 3 or 4 days. And this continued fluid resuscitation beyond the 6 hours are, for me, the culprits, where we are afraid of over resuscitating the patient, and rightfully so. I mean, we should not be doing that. But conversely, that should not mean that your initial fluid resuscitation should be incomplete, because that in its own right also has consequences. We know from the studies that indeed some of these consequences may be more subtle, like central nervous system effects that may be only detected a few months down the road. But we need to understand that hypoperfusion, and not only looking at the skin, can be very helpful, but also different organ systems may be suffering when we under resuscitate. So finding the right balance, Bharat, it's challenging.
Challenging.
I admit, but I also warn against under resuscitation in the first phase, under resuscitating patients, especially, and this is often not considered, some categories of patients who may be particularly prone to being under resuscitated. You means know that I'm a surgery trained intensivist, and abdominal infections are still one of my major clinical interests. Well, patients with abdominal sepsis, typically, whether they come from the community or from the hospital, have had reduced intake over days, and they typically come with a much higher fluid deficit. They've been vomiting, they've maybe had diarrhea, they've lost a lot of fluids maybe in their peritoneal cavity. And those patients, probably much more than say the 75-year-old patient coming in with the pneumonia or developing hospital-acquired pneumonia, that's a different ballgame. So it's also, again, it's about using your brains. It's about using your clinical insights and not just saying, I will not give fluids or I will give too many fluids, if
So,
that's helpful.
so it's very rightly said, as you put it across. The most of the pulmonary edema cases or the fluid overload, what we see is when we continue that kind of a fluid beyond 6 hours for more than 12 hours or 24 hours. So initial fluid
Mhm.
resuscitation, the real septic shock patient shouldn't become a more of a problem, and we should also be worried about the under resuscitation.
Yeah,
So
but of course, at the same time, I think it's okay, and we'll probably see more tendency towards earlier use of vasopressors. If of course, if you see that your first 500 mLs has no impact at all, and especially the diastolic blood pressure remains very low, then that patient has vasoplegia and needs vasopressors. So again, it's about trying to apply physiology at the bedside, and again, resuscitation is very important, but you cannot standardize it for everybody. You need to have your brain, and you also need to look at the patient. You need your eyes.
So you answered my next question. That was the timing of vasopressor. So as you said, if our initial 500 bolus is not working, maybe we can consider starting vasopressors at that moment. So we move to the next one. So we talk of the biomarkers in the sepsis. So do they really make a meaningful change in the ICU decision, especially in case of the sepsis? Or if you talk of the lactate trains, maybe the procalcitonin or the
Yeah,
CRP, are they decision drivers or just a supportive makers?
yeah. I think there can be decision
Supportive
drivers, but
markers.
it depends on what kind of decision we're talking about. And let's maybe first look at the at the diagnosis. How helpful are they to diagnose sepsis? And I think the evidence base is quite solid there that PCT, CRP are not considered to be helpful to guide the initiation of antimicrobial therapy. Does it mean that it's so? This means that if you just look at the value of PCT or CRP, it's useless. But of course, at least I in clinical practice, I look at multiple things, and biomarkers can be one of the things. For me, it's very important to first also know if you have any historical data to compare with. If you have like daily trends in biomarkers, that's much more informing compared to like a single value. I think single value when it comes to biomarkers are of little use. And of course, if you have a patient who's been in your ICU, has very low inflammatory mediators, CRP level, PCT level is low, and then the patient, something happens, the patient deteriorates, and then the biomarker goes up. Well, I would say, okay, do you need a
Okay.
biomarker to confirm, what you should have picked up clinically? If the FiO2 goes up, doubles, well, if then the biomarker doubles, of course, you look at your patient and you try to understand what is happening, and maybe biomarker can point you to something, but to diagnose and to initiate antimicrobials, biomarkers up till now, I mean, this is the holy grail. This is something we're all looking for. And if you find it, give me a call. But this is not what biomarkers can be used for. At the other end, at the end of the treatment and trying to define when you can discontinue antibiotics, I think this is where biomarkers have probably the most solid evidence now, and indeed that PCT has been studied most extensively, that PCT, and again, trends in PCT can help you to identify patients in whom you can stop antimicrobials. Typically, you will gain a few days of antimicrobial therapy. And the challenge still is, of course, to keep antibiotic therapy short, like 3 to 5 days. Most studies have shown that you can reduce antimicrobial therapy from 10 or 12 days up to 7 or 8. Then again, I would say that for the bulk of the infections we treat in the ICU, the evidence is already clear that you don't need 2 weeks of antibiotics for most of the infections. Okay, and I'm sure we'll say, well, osteomyelitis and ventriculitis and endocarditis. Of course, there are exceptions, obviously, but the 80, 90% of the infections we treat can still be treated with 7 days and probably shorter. Because why do we say 7 days? It gives us this feeling of completeness. 7 days is like 1 week. The circle is round, right? But there's no biological rationality. The pathogens have no idea what day of the week it is and how long they've been exposed to a certain antibiotic. So probably other solutions apply as well.
So you've answered the half of my next question, that is, how do we de-escalate and decide the duration, especially in
Yeah,
the
well, they're linked. They are linked, unfortunately. Well, fortunately, unfortunately,
yes. No, but unfortunately,
biomarkers.
yes, yeah.
Yeah, and again, it's the decision to start antibiotics depends on the severity of illness, of course, of a patient. With a patient in shock and really factors indicating, even if you have not formal confirmation of infection, you would initiate antibiotics and still, of course, reevaluate. And it's the same for patients where you're not so sure and you do some extra investigations. Um, this is yeah, you can still initiate antibiotics a few hours later, but that still doesn't should not keep you from trying to confirm or refute the diagnosis of infection. It's not because you start with antibiotics that you walk away and you go mind doing something else. That's not the idea. You start antibiotics, you keep looking for the source. If you're unable to find a source, and maybe one day later you say, well, I was wrong. And please note that this is something we all have difficulties with. Like I took a wrong decision. It's hard to admit. But if you truly find an alternative diagnosis, if your patient has atelectasis or pulmonary embolism and not pneumonia, well, then you discontinue antibiotics. That's pretty straightforward.
So how do you choose empiric therapy, especially how do we approach sepsis when multi-resistant organisms are suspected or confirmed?
Yeah, yeah. I think when you
Combination
initiate
therapy,
antimicrobial,
stewardship principles.
yeah, that's of course the challenge, and trying to keep everything within stewardship principles that are essentially aimed at avoiding or reducing antimicrobial resistance development. And we know that the biggest contributor to that are antimicrobial use itself. And this is a vicious circle. If you work in an area where there's a lot of antimicrobial resistance, your empirical therapy will be broad and multiple drugs, and that in itself will also further select even more antimicrobial resistance. So it's important to try to break that cycle. So how to go about this? I think the first step still is having a tentative diagnosis, because depending on the diagnosis, still your empirical choices may be different. Pulmonary infections, you may treat them differently from abdominal, where you need an antimicrobial cover, from meningitis, from maybe catheter-related infections, where you're more concerned with gram-positives. So you need to understand that having an idea of where the infection is ongoing is an important aspect. The second one is your local ecology, and linked to that is your local antimicrobial guidelines, because your local guidelines should be informed by your local ecology, the biggest problems you have in your unit, and you should target them. You should not target every imaginable pathogen that you may encounter, or if you have encountered in your whole career. It's about the probability that a certain resistant pathogen is involved, and local ecology is a big driver of that. So knowledge of that and having an antibiotic formulary that is linked to that, where specific pathogens, specific infections are treated with specific selected antibiotics is the way to go in terms of choices. And so for me, two important elements is the focus of the infection and the ecology, which essentially together will result or should result in antibiotic guidelines, antibiotic recommendations at your institution level.
So my next question, I mean, you are the best person to ask. We often face the situation. So in hemodynamically unstable septic patient requiring
Mhm.
surgical source control. So of course, the patient is on multiple vasopressors, inotropic support, and surgeons understandably reluctant to operate because of high perioperative risk. So what should be the intensive led approach? What should be the timing? How do we uh, bridge this and convince
So
surgeons? So what is your take on this?
to obtain source control.
So they would, of
Yeah,
course, say the patient is on multiple vasopressors. If I take him to the OT, high
yeah,
chances of mortality. Then how do we?
yeah. It's balancing things out, of course, and again, the first step is having a diagnosis, and source control is important, but it's also important to understand that source control not always means surgery. And source control is as much as about removing an infected catheter, which can be done at the bedside, or draining percutaneously an abscess, which you can do using ultrasound. So there are many different flavors of source control. We do see a trend towards less surgical interventions, with newer technologies becoming available, and interventional radiologists becoming more experienced in draining such infections. But you're right, when a patient is severely ill, when there's severe metabolic disorders, the basic principle is always do not harm a patient. And inflicting more harm is something that, of course, also surgeons are aware of, that there's this risk. You have to minimize the risk, I think, and this basically comes down to choosing the right methodology and understanding that source control not always is like making a big incision, and then maybe injure bowel that then lead to new perforations, etc. It is also important to understand that, of course, for some forms of source control, you need others. You need your friends from the surgery department. And rather than involving them late, I always like to involve them early on. When you know that there's a patient coming in with maybe complex abdominal or thoracic or whatever disease that may be treated now with percutaneous drainage initially, I still like to involve them already and say, like, well, this is the patient. Let's look at what the options are. Probably we can drain it percutaneously, but immediately you can already discuss, like, well, if this is not working, we may need to resort to surgery. So involving your surgeon friends early on is important, and involve them in the decision making, and not, call them and say, like, we have this patient, you have to operate them. I think nobody likes to be told what to do, and I'm sure surgeons are among that group. And I'm sure it's the same everywhere around the world.
Yeah, I take that from you, and it's a difficult scenario. But as you rightly said, surgeon friends, we have to talk to them, and we have to
Yeah,
involve them in decision making rather than ordering them or
and
telling them what they are supposed to be doing. And
yeah, like
for the
like we have
minimal
this
invasive
complex
approach,
patient. We have this complex patient. Please come help us.
yes, that's the way.
That works better than, we'll send you this patient and you need to cut out this and that.
Yes. Yeah, so got this, and it's a very good message and learning for all the critical care trainees how to approach the surgeons as well. Um,
Yeah,
so now we talk of the unique challenges the sepsis management faces in resource limited setting, be it the diagnostics, delayed presentation, antimicrobial availability, ICU
yeah,
constraint, and how outcomes can still be improved in those areas.
yeah. Yeah, I understand, of course, that low resource settings are always more challenging, and admittedly, sometimes these interventions seem like difficult to implement. But at the same time, I think we've seen a number of interventions recently that also are applicable and more easily applicable in low resource settings, and maybe even more useful there. We've had the capillary refill time to guide resuscitation rather than maybe complex invasive cardiac monitoring tools, or transesophageal echocardiography if you do not have an echo machine. Along the same lines, I do think, for instance, also continuous or extended infusion could also be an not so difficult to implement from a technological point of view procedure in lower resource settings. And please correct me if I'm wrong in that, but I think it may be a smart way, or a relatively simple way, to use antibiotics in a smarter way rather than have to resort to these new and expensive and not easy to get antimicrobials. A smarter use of our current armamentarium may be the solutions. So I think there's also an increasing awareness of this among sepsis researchers and clinical researchers around the globe, that it's not only about considering what may work in your high-end institution in the US, but also think of more difficult, more challenging circumstances, and what we can do for those patients.
So the last would be, how do we recognize early treatment failures in sepsis? I mean, I know this is a septic shock patient. As you said, I have to choose an antibiotic depending on the current ecology, but also it's very important to know this is not working uh, in
Yeah.
my area. So what could be the areas where we have to look into despite achieving guidelines, recommended targets? I have to find out this is
Yeah.
not.
There's a number of issues, of course, that can be going on when a patient is not improving. Well, first of all, I would say, like, give the patient time and don't start worrying if the patient is not improving after 1 hour. Because, I mean, fluid resuscitation, vasopressor therapy, etc., it will take some time for the lactate to go down, for the tissues to be, to be better perfused. So you need time, and don't jump the gun and expand your antimicrobial therapy 2 hours after your initial initiation, unless, of course, an alternative diagnosis where a new pathogen was detected. So I think it's important to understand it does need time. Um, if you take that time and say after one day you see everything still deteriorating, because you do want to see some stabilization at least, assuming that the patient does not have like severe comorbidity. If your patient has, like, I don't know, like valvular disease or ischemic cardiac disease or severe pulmonary issues, well, then of course you may run into bigger problems because one of the organ systems is not able to keep up. If the patient was already suffering from a chronic kidney disease, still having urinary output and being able to clear everything just sufficiently, well, those patients, they will develop acute kidney injury. Even if they improve, their kidney function may deteriorate. They may have to put them on dialysis, although the sepsis, the infection, has been treated adequately. So these comorbidity patients are, I think, a challenge. And it's important to understand that sometimes comorbidities may come in and may, hamper the straightforward repair. Still, if you're still worried, and then I think from an infection point of view, a number of things need to be considered. Well, first of all, revisit the diagnosis and understand there could be more than one diagnosis as well. You may have a patient suffering from, like, a perforated bowel after surgery and having a pulmonary infection at the same time because they were unable to breathe properly and they've developed a pulmonary infection. So multiple infections may effectively be there. And then linked to that is the treatment adequate in terms of antimicrobial therapy? Suppose your patient was admitted after surgery, you started with cephalosporin to treat the pulmonary infection you've diagnosed. If then an abdominal infection is there, well, you may have, of course, anaerobes involved, you may have yeast involved. So you need the diagnostic, the focus idea is very important to select the right antibiotics. And the other one is source control adequate, especially for those patients who've been operated on? There is quite a body of evidence showing that even if the surgeon is convinced at the end of surgery that the source control is like this, that in many, many different patients, the source control was not as good as the surgeon would have hoped for. And there is a problem. So investigating source control is necessary. But this can also apply to a patient with community-acquired pneumonia, where maybe indeed the initial treatment was okay, but after a few days, an empyema develops, and that becomes the driver of the continued failure to improve. So looking for maybe complications in terms of complications that require source control is equally important. Just to avoid that you immediately jump the gun, you expand the antimicrobials. It may be necessary, but it may not always be necessary.
So we come to the end of this, and as we conclude today's episode, I extend my heartfelt thanks to Professor and President of ESICM for sharing his expertise and his vision of sepsis care and your insights into antimicrobial optimization, continuous beta-lactam infusion, for undoubtedly influence practice across ICUs worldwide. Thank you very much for being with us.
It was a pleasure. Thank you very much for the opportunity.